Welcome to Orthodontic Smiles, the podcast designed for all dentists and their staffs who practice orthodontics. This podcast is brought to you by the American Orthodontic Society. With innovation, quality, patient comfort, and efficiency as their goal, Henry Schein Orthodontics has once again achieved a new and exciting breakthrough in aligner therapy, introducing a clearly different aligner system, a comprehensive aesthetic solution for adults and teens. The SLX Clear Aligner System is uniquely clear, provides an excellent fit, and offers numerous treatment and workflow efficiencies. With over 50,000 patients treated with this innovative aligner technology, doctors and patients can be confident in the SLX aligner performance for a full range of minor, moderate, and comprehensive treatments. Jumpstart your SLX cases with the Carrier Motion Appliance to provide the most efficient and aesthetic treatment solution available. For more information, contact your Henry Schein representative or email aligners@henryschein.com. Our guest today on Orthodontic Smiles podcast is Dr. Yosh Jefferson. He's a general dentist in Mount Holly, New Jersey, and has been practicing for about 35 years. Somewhere along the way, he had developed a strong interest in orthodontics, and over those years has incorporated functional appliances and has developed a very unique knowledge of facial aesthetics. He is an author, an international lecturer, and he is a diplomate of the International Association of Orthodontics. Well, welcome, Dr. Yosh Jefferson, to Orthodontic Smiles podcast. We've spent a lot of time trying to get you on our broadcast because I know how much you have, how much an interest you have in orthodontics and being a GP, but doing orthodontics for years. Gosh, Yosh, I haven't seen you in many years, but we've known each other for 30 years, at least that, hasn't it been?
It's been a long time. We're showing our age.
Exactly, but we're still practicing doing orthodontics, and I think we have a lot to offer those that are just getting started in it or have been doing some orthodontics that might be different from the way you practice. You're right. A big proponent. For years, I've listened to you lecture, and you have lectured all over the world, specifically about facial beauty. And I'd like that to be our theme today as we talk about facial beauty and orthodontics. And I want you to kind of get us started with that. I know this goes back thousands of years, and you in your lectures you kind of formulate the theories behind facial beauty. So why don't you get started and kind of give us an update from 1,000 years ago to now?
Well, I'll tell you, first of all, when I started doing orthodontics, facial beauty, enhancing facial aesthetics was my big thing. I didn't care about TMJ. I didn't care about airway, but we're talking over 30 years ago when that wasn't such a big deal, but now it is. However, when I started looking into facial beauty, I said, if we're doing orthodontics, especially functional orthodontics, and we can change the size, shape, and position of the maxilla and mandible, we can literally change facial appearance. And we can either make it worse or make it better. I liked to make it better. Well, if I'm going to make it better, then what is facial beauty? what is the definition? And so many people said, well, it's different for every race, age, and sex, and it's subjective, and you can't really define it. And I wouldn't take that as an answer, because then we're just throwing darts when we're treating our patients. We have to have an end game. We have to have a goal. So I started reading Robert Reckitt's article on Fibonacci numerical series and its biologic significance. And I read it. I had to read it 3 times before I finally realized that he was talking about divine proportion. And divine proportion is not new. It's been around for a couple of thousand years. It was originally discussed by a sculptor by the name of Phidias, a Greek sculptor, and he talked about proportion. So it's divine proportion, golden proportion, phi, whatever you call it. There is a numerical number proportion, and that number is 1 to 1.618, and that's a very important number.
Well, give me an idea, Yosh, how that applies to the face so that our listeners can understand how proportion of the face is measured.
Sure. I mean, within the human body, there are probably millions of proportion based on the 1 to 1.618. Even our chromosome is based on the 1 to 1.618. But let me just take one aspect of the face. If you take the measurement from the top of the head to the bottom of the chin, and also from cheek to cheek, okay, the cheek, from cheek to cheek, which is the widest part of your face, if that's 1, then the length of the face from the top of the head to the bottom of the chin should be 1.618. If it's shorter than 1.618, I call that a short face syndrome. If it's longer than 1.618, I call that the long face syndrome. And so consequently, as we all know, the shorter the face, there's aesthetic problems associated with it. And if the face is long, the longer the face, there's aesthetic problem associated with that. But if it's within 1 to 1.618, the face looks very good.
Great. That's a good explanation of the divine proportion of the face. And so we strive in functional orthodontics to develop the face so that it meets those criteria, correct?
Correct. Not just, in one dimension, but let's go anterior posteriorly. We're talking about the profile. There is only one profile that is universally accepted as being beautiful. And people say, well, what about blacks, Asians, Hispanics, Middle Eastern? They all have different criteria. I said, nope. There is no one race or ethnicity has a monopoly on the perfect classic profile. Every race has that. And if you treat to that profile, no matter what race you are considered having a beautiful profile.
Could you give me an example of what, if you looked at someone very quickly, how you could determine they have a beautiful profile? Not just that they're beautiful people, but if you had a measurement of some sort.
Well,
I'll give you an idea of what I'm talking about.
I can give you an example of like movie stars and.
No, what I do in my practice is I kind of look at draw a line from the nose to the chin, and if I can get the lips pretty close to that line, usually I think that they have a really nice profile. For girls, maybe 1 or 2 millimeters in front of the line, and for boys on the line or just behind it. That's my aesthetic criteria for what looks to be a nice profile. So with that said, if I have a young person who has lips way behind the line, my criteria would be to try to move the maxilla and the mandible slightly forward to develop the lips so that they have a much more aesthetic look.
Right. I think you're talking about the aesthetic line
Yes.
from nose down to the chin. You can use that. That's not always accurate because, you know,
Everyone's different.
everyone's different. Uh, I don't want to get too involved about measurements because, believe it or not, genetically, we have the perception within our brains. You can look at a face and tell whether there's something going wrong or that's perfect. However, I'd like to talk about a cephalometric analysis. I call that the Jefferson Ceph analysis. I'm not going to say that I developed it because it's basically a analysis, a Sassoon archaeoanalysis, but it's much modified and it's much abbreviated. So I took out 90% of his measurements and just broke it down to the anterior arc and the vertical arcs, age 18.
Let me say you've been teaching this for probably 20
Yes.
years, at least that.
Yes. And there's other instructors out there that are teaching it. And believe it or not, my analysis is going worldwide. I've had people contact me from Africa, Middle East, Asia. There's one dentist from Indonesia. He wanted to buy. I wrote a manual called Jefferson Ceph Analysis. He wanted to buy my manual and for his son. And basically, his son was going to an orthodontic program. And he got the book and he wrote his thesis on the Jefferson Ceph analysis.
Wow.
And he graduated. So he did come to one of the meetings. I got to meet him. I got a picture of him and I together. And I said, did you tell him that I was a general dentist? He said, no. He had a big smile. But he said his professors absolutely loved his thesis. So it is becoming recognized.
Yeah, no, even dolphin imaging has your thesis in it, doesn't it? I mean, your
Right.
analysis. So
Right.
if you were to buy dolphin imaging, which most orthodontists and GPs that do orthodontics buy, your analysis is in there, so you can utilize
Right.
it. Will you be teaching a lot of or some of this at the annual meeting of the American Orthodontic Society in September?
I'm going to go over my Ceph so that people can understand it, but I can't. We're talking. I'm only lecturing for 4 hours. So there's a lot of stuff I'm going to be covering. I'm going to be covering how to easily treat skeletal 3s, easily treat skeletal 2s. We're not talking dental class 2s or dental class 3s. They are extremely simple to treat. I'm talking skeletal, where people have a 9 or 10 millimeter overjet, okay? And we have to bring the mandible forward or maybe even bring the maxilla back a little bit. But I have a technique called fixinator. I use that in children, teenagers, adults. You don't have to use any labs to fabricate it. It's a wonderful technique. Skeletal 3s is considered the most complicated orthodontic problem to treat. I find it to be the easiest. And I use what we call a Frankel 3, which I'm going to teach at the meeting in September. I will also be talking about Fixinator at the meeting. But as far as the Jefferson Ceph analysis, I will present it so that people can understand it. And it's not that complicated. And the beauty of my Jefferson Ceph analysis, it takes 5 minutes to trace and diagnose. Now, I don't know what Ceph analysis you use, Ed, but how long does it take you to trace and diagnose?
Well, it does take a little bit longer, but I have the beauty of using dolphin, which makes it a little bit easier. But even at that, entering the points and getting the analysis is time consuming. There's no question about it. I've kind of broken mine down into just certain numbers that I use, especially when I'm doing early treatment orthodontics. I don't think you need to get as critical at that stage. But
Right.
when I'm doing early orthodontics, early treatment orthodontics, there's certain principles that you need to be able to make a good diagnosis. And I'm really, I think that that's the most, of all the things in orthodontics that we do, whether they be mechanical or not, I think the most important thing is the diagnosis to start with. Most dentists get in trouble by not making the right diagnosis.
Exactly. If your diagnosis is wrong and you treat to that, you're going to have major problems with your patient's treatment, major problem with patient's happiness. And medically, legally, you might get into trouble. So it's important to, be able to diagnose correctly from get-go. I like to make a comment that if anybody wants to learn or try to see what the Jefferson Ceph analysis is, just go to any of your web, like Google or any
search sites.
Yeah, and just type in Jefferson Ceph analysis video. There's a video instruction. It's free. You don't have to pay for it. It's up there, and you can really try to see how fast and simple it is.
Yes, it is. I've sat through many of your lectures as you speak about it and shown how you do it, and it is very, very simple and very understandable as to where you put the teeth and where you need to put the teeth to be able to come out with the best aesthetics. But I'm more interested.
Let me just make a correction. You're talking about teeth. The Jefferson analysis is more skeletal.
Yes, yes.
Okay, it will tell you anterior posteriorly exactly where the maxilla should be, where the mandible should be, and vertically where the menton should be at their age.
Gotcha. And well, wherever the bone is, the teeth are. So that's there's no question about that. But you're right, it is the bone.
My philosophy is to treat the skeletal foundation first where God and nature intended, and then put the teeth.
Well, I'm interested in how you're doing that. I mean, we'll get into some different ways of treating, let's just say a skeletal tooth. Give me an explanation, or at least an understanding of how you're doing it.
Right. I used to use bionators and herbs and rechinators and things like that, but I just did not want to have to deal with lab. That you have to wait, take impressions, send it to the lab, and then you have to wait 2 or 3 weeks to get it. With what I call a fixinator, it's basically a rechinator, but you just put a bite ramp that you bond behind the anterior centrals, and the lower teeth rests on that.
And for the back teeth to come together, they need to shift the jaw forward. Is that
exactly? It helps. A lot of skeletal class 2 patients not only have retrognathic mandible, but they have a vertical problem. Their verticals tend to be short, and they also tend to have TMJ problems. So by using the fixinator technique, which I use the bite ramp in conjunction with a self-ligating frictionless bracket with hooks, it just simplifies the treatment enormously. I've done so many patients using that technique, and it's beautiful because you can use it on children, teenagers, adults, elderly patients. It's a very fast, quick, and easy way to treat these cases. And basically, technology and, things that keep changing so fast. Would you agree, Ed?
Oh, absolutely.
Okay.
I'm curious if you have used any of the carrier motion appliances.
No, because carrier motion, is that for treating skeletal class 2s?
Yes, it is. And
yeah.
it originally wasn't. It was originally called the carrier distalizer, and then since that time, with his research that he had done, he found that he could correct a skeletal class 2 very, very quickly, with the appliance in place. And I've been using them now for, well, my youngest grandson is 21, and he was 9 when I first placed a carrier motion or carrier distalizer in his mouth at that time.
Right.
And he was a big time skeletal too.
Right.
With the lip dip and the whole thing. And,
how big of an overjet?
Oh, he was a 9mm overjet, so he was big. He was big. And I put that on him, and to be honest with you, within about 3 months, he was totally corrected. Totally corrected.
Well, that's amazing.
I have done this with other patients that have even worse,
right?
And had corrections even quicker than that. So it is, and then you just go straight to, your straight wire appliance, and you correct them very quickly. So, to be honest with you, I think Carrier has taken the hardest cases, which in orthodontics we used to consider skeletal 2s to be the hardest cases, and he's turned them really virtually into the easiest cases that we treat. So I would encourage you to try it and see. It changed my whole view. I practiced orthodontics very much like you do, and this one appliance really has changed it. I'm curious to see this appliance that you're talking about, because it basically helps the jaw come forward naturally.
Well, Ed, do you
wear rubber bands with this appliance?
If you want to super erect the posterior teeth, use vertical elastics to extrude the posterior teeth. That would speed it up, yes.
I'm trying to picture it in my mind, Yosh. So basically what it's doing, it's holding the lower jaw forward until the premolars super erupt into interdigitation, correct?
Correct.
All right, so it's very much like the Herbst appliance, except it's not as big or forceful as the Herbst appliance would be.
Right, and there's no lab bill involved.
Charge, yeah.
And the other thing is Herbst, for every action, there's a reaction. So to bring the mandible forward, you're also pulling the maxilla back. So there is that issue going on.
Yeah, there's a lot of controversy using the Herbst because of airway. Moving that maxilla backwards is actually impinging on the airway. Of course, with this motion appliance, the research has shown that doesn't happen. It's the mandible that comes forward, which is an advantage. And I think that's why it's gotten such popularity all over the world. And besides the fact that the manufacturer has had to be millions of dollars in the marketing of this all over the world. So there's a lot of people out there using it, and I think they're getting some of the benefit of it. But I'm always interested to hear how different people treat it and their reasons why. That's why we have
Ed,
these broadcasts.
I'm not the only expert. I learn from other people, so don't take my treatment as the gospel. There's always other treatments. There's
you're open-minded enough to
there's more ways to skin a cat than one way, and anybody that feels like, I got all the answers and I'm the person, I don't enjoy listening to people like that. They have to be open-minded.
Sure, and we should be open-minded. That's how we have come so far from using the bionator all the way to appliances like you're teaching. So,
but I'll tell you another thing, Ed. You and I think outside the box, and sometimes you have to think outside the box to make progress. Because if everyone thinks alike, then there's no progress. So that's what I appreciate about you, because you are open-minded, and And whenever I lecture, I like to lecture to doctors that are willing to open their mind and, listen to what I have to say, as well as I love to hear what other people say.
Well, that I think that's the reason why we now it's pretty generalized that all through the orthodontic world that we are treating early treatment orthodontics. If you remember back 20 years ago, GPs and pediatric dentists were the only ones treating early treatment orthodontics, where the orthodontist used to say, no, that's not the right way to do it, or it's fallible, or you shouldn't do it that way. We continued on and now have developed some great techniques for treating kids so that they don't have to be in braces as long, and we're ending up with really, really great results. So even now the orthodontists have bought in to doing early treatment orthodontics.
Well, guess what? The GP that do orthodontics were the ones that started using straight wire brackets.
Oh, yeah.
Okay. The GPs were the ones that started using functional appliances because of our great instructor, John Witzik, who I consider the father of American functional orthodontics. We talked about facial beauty. We talked about TMJ, temporomandibular disorder. We talked about sleep apnea or airway issues. So all the major innovation in orthodontics were started by GPs because we are willing to open up our mind and see far beyond what is currently, being done today.
Well, let me ask you this question. You're pretty an innovative guy. Are you using any Invisalign?
I will tell you that Invisalign will only correct minor, maybe some moderate cases, but they don't make skeletal corrections that much. If they do, I'm going to tell you my practice, I tackle some of the most complicated cases that a lot of even the specialists won't touch. Cases that specialists have said it's a surgical case, and I treat it non-surgically. So you can't treat some of these very complicated skeletal discrepancies, especially very narrow palate. Imagine treating narrow palates where the palates are almost touching each other. They're kissing palates. We're talking about kissing tonsils, okay?
Yeah.
You can't treat that with Invisalign. And I get patients coming from, different parts of the country, California, Florida, North Carolina. They're flying in, to be treated because no one else can do the treatment that I do. So when you say Invisalign, I have associates, they do Invisalign, but I don't do it. Not that it's wrong, okay, but in the right cases where we consider minor and maybe moderate cases.
Yeah, minor to moderate tooth movement.
Tooth movement, and it's pure dental problems. If it's a skeletal problems, I don't, especially, like very complicated skeletal problems, you can't treat them with Invisalign.
And unfortunately what's happening is that the people that are walking in the door to most dental offices, GP or orthodontist, that are older, it's much more difficult to correct those bony problems, and therefore they're trying to do align products to correct just the crowding issues. I'm a proponent of doing early treatment orthodontics on young kids. Get the bone in the right position, and then if you want to use an Invisalign product when they're in transitional or early permanent dentition, then you can do it because you've already made the bone big enough.
Right. I'm glad you brought that. I'm glad that you brought it up because that's probably how I use Invisalign in my practice, because there are patients that just do not want braces. Okay. So what I offer them is, look, and using my Jefferson Ceph analysis, showing that we need to either bring the maxilla back a little bit, or we have to bring the mandible forward, or we have to increase their vertical, what have you. I said, Invisalign will not correct that, okay? But let's use functional appliances and widen the mouth and then reposition the mandible to where it should be. And once we get to that position, instead of using braces, we'll use Invisalign, and a lot of patients will go for that.
Yeah, I think that's the future. I'd like to see that to be the future.
Yeah.
Of an aligned product, because I worry that we're trying to just straighten teeth, and that's not going to help that child who already has pediatric sleep apnea and is going to develop into an adult with severe sleep apnea. We have to tackle the bony problems very early
Exactly.
while that child is developing, and then they'll have a better chance of not having these severe sleep apneic events.
And you know what? Treating early is ideal, but that concept came about, when it came about recently, and there's adults that have skeletal problems that that concept wasn't around when they were young.
Right. That's very, very true. So you've developed methods of treating adults, like you said. You do expansion all the way up to what age would be the oldest you've done expansion on?
Probably in the mid 60s, and like I will do somebody in the 70s and 80s as long as they're robust and healthy and have no medical problems. Of course, some patients, elderly patients, have medical problems, and they walk in and they're very not very healthy looking. Then I wouldn't do that. That would be too much stress on their face and body. So no, I would stay away from that. But if they come in robust and healthy and no medical problems, I'll do it if they're 90 years old.
Yeah. I'm just curious, is it painful for the older they get?
It's slower movement, okay, but I've treated patients in their 60s, and I don't ask them if it's any more painful than if they did it when they were a child, because they don't have any way to compare. But the end result is, if they're cooperative and they wear the appliance as instructed, we'll get them there. It may not take longer than 3 or 4 months. It may take 5 or 6 months, but we do get the results.
That's great. That's great. I'm so anxious to hear your lecture. I haven't heard you in quite a few years, so I'm kind of curious to see how you have changed over the years and what you're using to treat your patients with. So that will be in September at the American Orthodontic Society meeting in Washington, D.C. So I look forward to seeing you there. I always ask this question of most of the people I interview. What do you think orthodontics is going to be like in the future? Where are we going? What direction?
Well, I will tell you that in order for orthodontics to thrive and to blossom to where it should be, we definitely have to be concerned about facial aesthetics. Take everything aside. A lot of people want to look good. That's the universal, right?
Yeah.
And there are a lot of people there that have, malocclusions and skeletal discrepancies that they don't like when they look in the mirror. So facial beauty is something that will cause them to walk into your office or the orthodontic practitioners that do.
You're basically, what you're saying is our ability to change the face to an aesthetic that they're comfortable with and that they would love to have is
right.
What's going to bring orthodontics to the forefront in most offices.
But there is a flip side. Okay. When I started doing ortho, my thrust was enhancing facial aesthetics. I didn't care about TMJ, airway. Back then, I took courses in TMJ, and these experts on TMJ lectured. And when I left, I was so confused. I said, you know what? I'm not even going to touch that. So all I did was treat patients to my universal standard of facial beauty, and I used my Jefferson Ceph analysis to help me get there. And I would tell you, I have not found one patient that when I treated to those criteria that they were unhappy. In fact, a lot of them were very thrilled. But what happened later on is I would see them, a month later for a post-treatment, and the patients would come back and say, Doc, I used to get headaches. I don't get them anymore. Or, Doc, I used to have trouble sleeping, but I sleep like a baby now. Or I had neck, back, shoulder problems, and I feel so much better, or hearing problems. So a big light bulb just popped out of my head. I said, you know something? There's something going on here. And then I realized that if you treat the face to a beautiful profile, to the divine proportion, and you can use the Jefferson Ceph analysis to guide you to where you need to be, okay? If you treat to that, not only do you beautify faces, but you make them healthier and you alleviate multitude of medical problems. How simple is that? That blew my mind. And now, before I didn't even realize that I was treating medical issues, now I will ask them questions. Do you have sleep apnea? Do you have migraine headaches? And then when they tell me yeah, and I look at their facial profile, I can tell by looking at their facial profile, I can tell whether they have TMD, migraine headaches, airway problems, sleep apnea. I can tell, but they don't even have to tell me. Okay, I can read the face. So the amazing thing is, we're not only can beautify faces, but we can alleviate multitude of medical problems. And if the patients finally realize that dental practitioners that do functional orthodontics can help you in those areas, my God, people will be beating down your door.
Exactly. I agree with you 100%. We have something to offer. There's no question.
So that's where I see the future, facial beauty, alleviating medical problems.
Yeah. Well, Dr. Yosh Jefferson, I want to thank you for being on Orthodontic Smiles podcast. It's been a pleasure. I have not spoken to you for many years, and I just was going through the list of the doctors that were speaking at the AOS meeting, and I said, oh my gosh, what a great guy to get on Orthodontic Smiles podcast. You have such a unique ability to put things simply, and I'm looking forward to seeing how you treat your patients in every respect, whether they be class 2s or 3s. So, Yosh, thank you so much for being on our show today.
Ed, and I'm looking forward to meeting you. We haven't seen each other for years, and you're one of my favorite guys. I want you to know that.
Well, thank you very much, Yosh. Well, thank you for tuning in to Orthodontic Smiles podcast.
Hi, my name's Dr. Brad Williams, and I've practiced orthodontics for over 35 years, and over those years, I've had some fantastic teachers like Dr. Bill Wyatt, Dr. Bob Garrity, Dr. Dave Jackson, and many, many more. And I'm honored now to be teaching orthodontics to a whole new generation of general and pediatric dentists. I want to personally invite you to enroll in one of my basic or intermediate hands-on courses through the American Orthodontic Society. We are committed to provide your entire staff the support and training you need to launch orthodontics in your pediatric or general dental practice. And to make the hands-on experience in my classes the best possible, I've partnered with an outstanding and very ethical company called OrthoArch to provide all the orthodontic supplies my students need. When my students start treating patients in their offices, they too will benefit, as I have, in partnering with OrthoArch for all their orthodontic supply needs. You can contact OrthoArch at www.orthoarch.com. See you in class.
This is your host, Dr. Ed Gonzalez. I want to thank you for listening to Orthodontic Smiles today. If you enjoyed our broadcast, please click the subscribe button. We'll be in touch with you in the future about our further broadcasts. Thanks for listening.